All right. Good evening, everyone. Thank you for joining us for Queen's Free Speaking of Health lecture series. Tonight's lecture is called Diagnosis Cancer, Now What? My name is Lisa Sakia. I'm with Corporate Communications here at Queen's, and on behalf of the hospital, I welcome you this evening. Now, it is my pleasure to introduce to you Dr. Shane Morita, our main speaker for this evening. He is the Surgical Oncology Program Director at the Queen's Medical Center. He is also an MD Anderson Cancer Network certified physician. He is a Big Island boy, born and raised in Hilo. He graduated with his MD, his MS, and his PhD from the University of Hawaii John A. Burns School of Medicine. He performed his general surgery residency at Harbor UCLA Medical Center, David Geffen School of Medicine at UCLA. He completed specialized training after that at the National Cancer Institute, National Institutes of Health, as well as the Johns Hopkins Hospital, the Johns Hopkins University Department of Surgery, where he was on staff prior to returning home to the islands. As I said, he is currently our Surgical Oncology Program Director. He also serves as clinical faculty for the John A. Burns School of Medicine and the University of Hawaii Cancer Center. He has been awarded several grants to study cancer. He also has a personal link with cancer as his father passed away from it. His mother is still living here in Honolulu. He is married to Dr. Jamie Tom, who is an emergency medicine physician and is a dad to 3 boys. I'm sure they're rambunctious, all of them, Josiah, Elijah, and Zachariah. It is my pleasure to introduce you to Dr. Shane Morita.
Thank you, Lisa. Appreciate all of your hard work in coordinating as usual. Today, it's going to be a little different format in the fact that I'm going to talk a little less here as far as less slides. There'll be some pictures, photos I would love to share with you, but I can't because they're too literally gross. But the highlights, I think, are going to be the patients that had the opportunity to help take care of, and they're going to provide you with their testimony that's really unscripted. They're speaking from the heart. I didn't really give them much, instruction per se. This is just from their heart and whatever they want to share with. So really appreciate that. Just to start off, I always have to say I have no disclosures. I don't work for a pharmaceutical company. The only thing is that I do have my life is chaotic. I have a wife who works and 3 children who keep me kind of busy. This is what Lisa had already said. My father was diagnosed in April of 2004. And for those of you who've been directly affected personally or even just by family or friends, I mean, it just really changes your life and actually turns it upside down. So I applaud all of you here who are going through it or have gone through it. It's a very challenging situation to be in. And I always tell people it doesn't discriminate. You don't get a free pass because you're rich or you have certain power or whatever. Everyone's affected, and we'll talk about President Carter who was affected, and also recently everybody knows that Congressman Takai at age 49 died of pancreatic cancer. So again, cancer doesn't discriminate, and the timing was always poor. It's never convenient. So the Holy Grail, everybody's looking for this. It's on Time Magazine, Wall Street Journal. Everyone wants to know how to cure cancer. There are certain folks with a mission, MD Anderson, to end all cancer. But it really is a very tough entity to deal with because there's just so many different types. I do think, to give hope, that the treatments are getting better. And we're going to have, whether we want it to not or believe it or not, but there's going to be a lot of cancer survivors, and we'll talk about that. In about 25 years, there's going to be over 25 million people living with cancer in the United States. So I'm going to just go over what sort of my agenda and objectives. We're going to talk about some brief background, how many people in the United States have cancer, how how many folks have cancer in Hawaii, how many will die, and really emphasize a few things that can be sort of modified to help with preventing cancer as well as early detection of cancer, what some screening recommendations. A lot of it comes from the American Cancer Society. I know there's a lot of websites, but I think the American Cancer Society and as a nonprofit and the National Cancer Institute as a governmental base both give really good resources. I'm going to also mention some terminology because there's a lot of I think words that are used, and sometimes I don't know if people truly understand them, so I'm going to discuss that, and we're going to have time at the end to further get clarity on that. Tips in preparation for consultation. A lot of this I learned honestly on my own and just from watching other patients, and I've taken that of some of my personal experience with my father, but also just from my patients and how they deal with this sometimes tragic condition. What is a multidisciplinary team? I'm gonna focus on that because cancer now we're no longer living in silos where one person takes credit for everything. It really takes a team of not only physicians and nurses, but a lot of ancillary providers, and something that oftentimes gets missed is the frontline folks, people who answer the phone, because just like a restaurant or a hotel, if they get a good good response or good feedback, they're going to want to come and visit your facility. So everybody is important. So the word that my editorial, but the word that I hate is the word just, because it minimizes someone's role. So everybody who takes care of a cancer patient, whether you're answering the phones, you're counseling them and support services, arranging their travel, everybody is important. So anybody who tells you otherwise, as far as I know, really doesn't know what it's like to have to take care of a cancer patient. So everybody's important. Advances, we're going to mention about targeted therapy and immunotherapy, and we're going to have some patients discuss what they've gone through or even currently are going through. And the panel that I have are patients that have decided to not get additional treatment. Some have gone through everything: chemotherapy, radiation, surgery. Some are on active treatment. They're on taking active targeted therapy or active immunotherapy. It always, I know this is recorded, but it always disturbs me sometimes when you go to some talks and you have pictures or discussions of patients that had cancer and then they no longer have cancer, but then what about all the other folks that are actually being treated? I think we have to bring some reality there, that there are side effects to some of these treatments, and again, the folks that are here, I commend you for bravery for being here. And we're going to talk about their patient testimonials. They're going to give their own perspective on what it's like to get that C word told to you, what it's like, how it affects your whole family dynamics, what it's like to have to go through surgery, what it's like to have to go through an operation for someone that you just met once and to give your trust to. And we're going to have a panel session with an open discussion, and really no question is a dumb question, so I encourage any type of question, any inquiry, we'll do our best to answer it. So just by way of background, over 1.5 million people in the United States are expected to be diagnosed with cancer this year in 2016, and over 500,000 will actually die from it. In Hawaii, we'll have more than 6,000 cases of patients being diagnosed, and you can see there that nearly 2,500 patients will die of cancer. As far as the leading sites of new cancer cases and deaths, as far as nationally what happens, typically males, prostate, and female, it's breast, and for both male and female, lung cancer is the #1 cause of death. A lot of this is available from the American Cancer Society website, and Courtney, who is here representing the American Cancer Society, can point you to some information. I think what I wanted to emphasize before we talk about specific situations is really the goal, I think, whenever you take care of a cancer patient, is to not, of course, try to prevent it. And we can talk about vaccines, avoiding, vaccines for such as cervical cancer, avoiding tanning boots for melanoma, tobacco cessation for bladder cancer, right? Many of you don't know that smoking can cause bladder cancer, obesity for pancreatic cancer, screening, mammography for, I know there's a lot of controversy, but, sort of the guidelines, mammography for breast cancer, colonoscopy for colorectal cancer. There's a low-dose CT scan that can be used now for early detection of lung cancer, and PSA for prostate cancer. Again, there's a lot of controversy in that, but I can refer you to various websites. But really, we want to mitigate, we want to minimize, we want to avoid late-stage disease. When it's late-stage disease, in general, surgery, which is usually the best therapy for solid cancer, it makes it much difficult to do, and really in most instances not indicated. Some risk factors that I talked to you about potentially preventing your chance of developing cancer is really to not smoke. We hear this all the time. I have cancer patients that I take care of, and I worry that they may develop a secondary cancer. They may survive their cancer, that they're being addressed, but they may develop a different type of cancer, such as lung cancer, such as bladder cancer. And again, as I mentioned earlier, there's other types of cancers that are linked to smoking, including pancreatic cancer, right? And not many people, I think, know that. And obesity, something that at least you can try and modify. I know there's some folks have a genetic susceptibility, but there are ways that you can modify, even getting nutritional counseling or speaking to other physicians about it. Trends in cigarette smoking in general, folks are smoking less, but the problem now is that electronic smoking is on the rise, and this is in high school students, upwards is 15-20%. Obesity, that is a major problem. It's becoming more and more commonplace, right? So someone who's obese, we know already there's some types of cancers that increases their risk. So these are things that we can modify, but again, and we have choices, just like smoking, just like wearing your seatbelt, you have choices, and hopefully those choices are done correctly to help avoid developing cancer. HPV vaccine, I can tell you that this is helpful for preventing cervical cancer in certain strains. There's also some initial sort of preliminary data about oral sort of head and neck cancers that are affiliated with HPV. What's happening, actually, there's a lot of controversy with this. In Japan, you may or not already seen the news, but the rate of HPV vaccination is trending down to some say 1%, because a few folks there's some groups, advocacy groups, or I guess, vaccine groups that have really rallied and said that, vaccine, that patients are getting some bad side effects, and sort of rallied around this. So in Japan, the rate has really declined, so that's becoming really an issue there. Tanning beds, you may think, well, who would visit a tanning bed? The rate is about 12% in high school students. I can tell you, when I was in Colorado, I went to a tanning bed once. We now know that visiting a tanning bed increases your risk of melanoma, because it causes severe burns, and burns at an early age increases your risk of developing melanoma. It's not only the chronic sun exposure, like you go to the beach every day, it's also that acute burn that you can get and blister, and that can set you up for other deadly cancers, including melanoma. Cervical cancer screening, I think is important. This is a way, again, picking up early. Pap smears, or in general, I think the Pap smear is used quite effectively here. Breast cancer screening, getting mammography, and again, there are certain guidelines that, I don't want to belay too much for the interest of time, but I can just tell you that it's estimated that in 2016, 130 women will die of breast cancer here in our state. So I'm hopeful that mammography and other screening modalities are used, but at least think about it when you talk about with your physician. Colorectal cancer screening, fecal occult tests. There's fecal tests that are stool. There is now a blood-based test. Actually, I don't know about the coverage, but now it's been FDA approved. Getting lower endoscopies. The amount of people dying with colorectal cancer in Hawaii is estimated to be 230. Lung cancer screening, again, if you meet the proper criteria, such as being a former or current smoker, there are some guidelines about low-dose spiral CTs. In Hawaii, 570 individuals will die of lung cancer this year. And that's a lot, and quite a bit is attributed to smoking. Prostate cancer, again, there's a lot of controversy with that. I always tell people, go and talk to your physician and have a good informed discussion, but using PSA and digital rectal examinations, 100 people will die of prostate cancer in Hawaii this year. Again, just to emphasize, you may say, well, what is late stage disease? What are you talking about? We want to prevent cancer, or we want to detect it early by screening, right? Because prevention, you do these certain sort of risk behavior modification, not smoking, watching your weight, what have you, that helps prevent cancer, and then early screening helps detect cancer early, right? So, for example, when you go and get your colonoscopy, maybe getting a polyp out or has early stage cancer, you can detect it early instead of waiting until you have bleeding or problems with your stool. But what is late stage disease? Sometimes patients come in and they have disease. So this is a patient who has disease here. This is a scan here, and you can see this is the spine, a tumor in the spine. So this is what we want to avoid. So go in. Any type of ailment, something, you know your body better. I'm not saying to be paranoid about everything, but if you're losing weight for an unexpected reason, you have this atypical pain that's not getting better, go and see your healthcare provider and please be evaluated. To terminology, again, I'm going to mention, because there's a lot of, sometimes I notice that patients come and see doctors, and doctors don't do a good job of articulating, and that's myself included. Sometimes you get lost in not being able to articulate the information to your patients. But prognosis, for example, things that you want to prognosis, basically you ask your physician, what is my chance of living? How long, what is my 5-year survival, expected survival? Diagnosis, what type of cancer, in this instance, what type of cancer do I have? Stages, how far has the cancer spread? So these are things that you want to know before you go in. Therapy is what type of treatment you're going to get, whether it's surgery, chemotherapy, immunotherapy, targeted therapy, radiation therapy, alternative therapy. There's a lot of different options now. A lot of folks will ask about a clinical trial. I think clinical trials are extremely beneficial because it answers questions that, if clinical trials weren't done, a lot of medications now that are approved by the Food and Drug Administration wouldn't be available for patients. And that's how we apply novel therapy to help improve outcome. So I'll talk about some clinical trials. Now, there's different phases you hear. Phase 1 is in general, is a phase 1 study is not determining whether or not the cancer treatment will be effective. It's trying to determine whether or not it's safe. So they try to determine what's called toxicity. What's a safe dose? Phase 2 is there going to be a treatment benefit? Is it going to help the patients live longer or prevent recurrence? And phase 3 is basically going head to head with what's called the gold standard, whether or not the new treatment is going to be better. So those are some phases that you may hear. And so if your doctor does bring it up, you want to at least have a background of knowing what these different terms are. And surveillance and is really, are you actively determining whether or not the cancer has come back? So you want to always have that with your physician. You hear this all the time, genetics, genomics. Really, genetics, study of hereditary genomics, is looking at all the genes, their functions, their techniques. A lot of time that's helpful for us as physicians when we're trying to determine a particular target in someone that may respond to therapy if they failed other types of therapy, and we'll talk about that a little bit later. This is just a reference that you can get the definition from the World Health Organization. The genetics, you're just looking for specific bits of DNA, and genomics, and it can be more hereditary. Genomics, you're looking at a wide panel and looking at different variations. I think I wanted to really focus on, now that we have this terminology out, a little bit more clarified, is what do you do when you get diagnosed? And I had mentioned this earlier on some different segments, but Courtney, who's out there at the American Cancer Society, has a folder. So I always tell people, get something, be organized, because once you get diagnosed, as I said, your life just turns upside down. It completely changes your dynamics. Get organized, get a folder to hold your medical records, especially if coming from an outside facility or going to an outside facility. Research your cancer. The more you know, the better, because if I have a problem with a certain condition, I think if I read up a little bit more, I'll understand it, whoever's trying to explain it to me. So the websites that I recognize are on there, cancer.gov, which is the National Cancer Institute, and cancer.org, which is the American Cancer Society. When you receive a diagnosis of cancer, or your family member or a loved one does, always get a core people together and meet before you go in and for that appointment, because you may have only 45 minutes with that physician or 1 hour, right? So you want to make sure you brainstorm the questions, make a list, and say, look, whatever it is, I want 5 things answered before I leave that physician's office. Okay? Do they use a multidisciplinary team? Ask them, do you work with other doctors, or how do you choose your doctors? What is it? Do you use a tumor board? And I promise I'd mention a tumor board. It's basically, we get together regularly, and many of them are weekly, and we essentially look at your x-rays, look at your scans, look at the pathology, and we have all different disciplines around the table. And we have navigators there who help coordinate the trial and say, this person is from Hilo, and it may be a little bit difficult for him to participate in a clinical trial. Or we have a physician saying, I don't know if he's going to be a good candidate for radiation because of his age. Or everybody talks about and renders their opinion about the selected case. So ask your doctor about that. Bring someone to the consultation who will take notes, because if you're like me, when I go and see my accountant, I have my wife taking notes because I'm just looking at him and just trying to digest all the information, and sometimes not paying attention because I'm in shock. And I'm not joking about that. Ask your provider for a timeline. You never want to have any miscommunication, because, for example, if someone says, well, we'll get to that shortly, or we'll do that CT scan to see if it's spread, we'll get it done soon. Now, your idea of soon may be like tomorrow, or in sometimes the patients that I see, like, can we do it this afternoon? Or it could be, and your physician may say, well, soon as well, we got to get approval for this, or we have to go and talk to different doctors. We want to meet for a tumor board yet to see. We don't want to order unnecessary biopsy, or we don't want to order unnecessary test that may give you more radiation. So that might be a week to them. So get a timeline, because I can tell you, just like I'm editorialing a little bit, like when my wife asks me something and I say I'll get to it soon, it doesn't mean tomorrow. It may mean a week or two. So really get an idea, because I'm telling you, miscommunication will cause a lot of problems. Okay. We talked about a multidisciplinary approach. It takes everybody. I mean, it takes a village to take care of one patient. And so I know sometimes patients think that they're the only ones, only sort of challenge for one physician. But I tell you, it takes a lot of doctors. We all need to get together and work together as a team. It takes a lot of ancillary folks, as I mentioned to you, navigators, social workers, oncology nurses. I mean, the list the list goes on indefinitely. It takes a village. When I was in Baltimore at Hopkins, we had a pancreatic cancer multidisciplinary clinic, and we try to do this here, but sometimes it's not always real time. But that's the concept that you want to work with. You want to make sure that all the doctors have gotten together, whether it's at a formal tumor board or at least on the phone, to say, look, did you go and what do you think about this? Is this something that, is this person a good surgical candidate? Is he survive the operation? All of this is really, really, really important. And that's something I think that's extremely beneficial, and there's a lot of data to support that. So at Queens, that's something that we always try to champion. These are many different folks here. There's who, and it really takes a specialized team approach to take care of cancer patients. I promise to talk about some more novel types of treatment, and one concept that's really changed. I mean, when I was in fellowship, this is something that was becoming much more, it was sort of the new thing, but it's becoming much more common now, but it's targeted therapy. And that's basically looking for a particular pathway or signal and trying to give a drug to only focus on that particular signal to decrease tumor growth or halt tumor growth. And it's been on time, and that started really with this drug called Gleevec. And Gleevec was FDA for a particular type of solid cancer, and some of you may already have this, but it's called a GI stromal tumor, and it was FDA approved in 2002. So what is a GI stromal tumor? It's a type of tumor. Most commonly, it involves the stomach, but it can be sensitive to a drug called Gleevec or Imatinib, and sometimes we give that before surgery. Again, we talk together. We have a discussion with other physicians and a tumor board. So this patient that I took care of, she was given this medication, Imatinib, also known as Gleevec, before surgery, and then we went in and removed it. And we did this to help decrease the amount of organs that we had to remove. As I told you, there's different pathways in cancer that targeted therapy tries to hone in on. So traditional chemotherapy can be very nonspecific and can cause a lot, sometimes really harsh side effects, because it's not only trying to destroy cells from the cancer itself, but also from normal cells. So you can have a lot more other side effects. Really one of the first example of targeted therapy was in 1998 when the FDA approved Herceptin, also known as trastuzumab, for breast cancer if they had a particular HER2 protein. And so that's something that's used today in breast cancer treatment. Imatinib, I mentioned, was FDA approved in 2002 for GI stromal tumors. Vemurafenib was FDA approved for melanoma in 2011. I provide a list. I mean, the list is endless, but these are all examples of what specific sort of targets or mutations within the tumor that this pill or other, in Herceptin's IV, but these medicines try to destroy and hone in on. So for Vemurafenib and melanoma, it's the BRAF gene. And you're not born with that gene, but it's within the tumor. Immunotherapy now has gotten a lot, and I'm going to play a commercial for you, but it's gotten a lot of publicity because immunotherapy is what President Carter has received for his melanoma. When I was a fellow at the National Cancer Institute, we were giving some of these drugs, and I tell you, patients got sick. And there's a lot of side effects. But now with the clinical trials, we know a little bit more what doses are effective. I can tell you, immunotherapy has really changed the landscape. It's been on Time magazine again. You make it on Time. This is real big news. Had a patient, previously showed you a CT scan of a patient who had Imatinib for his GI stromal tumor. This patient had one of the first FDA-approved drugs for melanoma as far as immunotherapy, and that was ipilimumab in 2011. And he had some side effects, but this is a patient with metastatic melanoma. So all this black stuff here, the brain, the way it works is the brain needs a constant supply of sugar, so this is not melanoma in here, but all these other sites it's all melanoma cells. So he underwent treatment for that. Now, when President Carter was diagnosed, he got a relatively newer treatment, and it's basically called anti-PD-1 inhibitor. There's a commercial for that. It's now approved for lung cancer, lymphoma, and even kidney cancer. But these are all advances that are made with clinical trials. So that's why clinical trials, again, are extremely important. So he received immunotherapy. There's different, how immunotherapy works. For really the short answer is, it really enhances your immune system, specifically T cells. So there's different types of white blood cells in your body, but T cells. So it's really important that the patient has a good immune system. And so some of these medicines, what they're trying to do, and we're going to have someone here tonight who's going to talk to you about what it's like to undergo immunotherapy, but it really just enhances your immune system. It augments, it just makes it better so that your body can fight the cancer. In many instances, it's melanoma, and now much more becoming much more of wave is for lung cancer. Pembrolizumab is a type of anti-PD-1 inhibitor that's given IV, that's given every 3 weeks to treat melanoma and other types of cancers. And then nivolumab is the one that now it's becoming very mainstream, not only for, again, not only for melanoma, but also for lung cancer. You may say, well, how mainstream has it gotten? Well, I'm going to show you, if you can bear with me for a few seconds here. You may have already seen this.
Advanced lung cancer called squamous non-small cell, previously treated with platinum-based chemotherapy. It's not every day something this big comes along. A chance to live longer. With Opdivo, nivolumab. Opdivo is the first and only immunotherapy FDA approved based on a clinical trial demonstrating longer life for these patients. In fact, Opdivo significantly increased the chance of living longer versus chemotherapy. Opdivo is different. It works with your immune system. Opdivo can cause your immune system to attack normal organs.
Okay, I think you get the idea of it, but I think you know, it's something that's really changed the way we treat cancer patients. As I said, a lot of these medicines, when we're giving at the NCI, patients were in clinical trials, but these agents have really changed the landscape of how we treat patients that have, you know, different types of cancers, melanoma, as I mentioned, and now lung cancer. So it's really overtaking chemotherapy. So I predict, for example, I was asked before about melanoma, but I predict that we're not even going to use one single type of chemotherapy for melanoma in the future. I mean, it's just, now it's either targeted therapy or immunotherapy. In very rare instances are we giving chemotherapy. This is just the FDA approvals. I can ask Lisa to put this on just in the interest of time, but there's so many drugs and advances that are being made daily, and again, a lot of it is due to clinical trials. So I always tell people, even if you have late stage disease, you know, don't give up hope. This is just some of the places that I've been to, and just to acknowledge to the training that and wonderful teachers that I've had, and I think really I want to just emphasize again that Hawaii is unique. We have a different culture. I think sometimes as physicians we focus too much on the actual tumor, but I can tell you that the individual patient is important. That's why there's a concept about personalized medicine, where you're looking also at the patient itself, because you know everybody may react differently. So Hawaii is unique, and I think a lot of the trials, the more people we can get into clinical trials, I think the more advances that we can have because of our diverse situation and population. I think what I wanted to just mention in a couple of slides in the interest of time is that the forecast is, and this just came out in 2016 from the National Cancer Institute, right now there's about 15.5 million individuals in the United States living with cancer, and it's going to go in 25 years to over 25 million. So cancer is going to be you know, a major challenge, because the longer you live, and they've called it the silver tsunami. A lot of older patients are going to have cancer too. So it's going to be a challenge in how we're going to take care of all these survivors. This is just a slide again for those of you who came in late of what I said about my tips. But again, I always just say, don't give up hope. You're going to get told something, and a statistic, as I told someone who asked me recently, who put me on the spot. I didn't know they were going to ask me that, but they said, well, what do, you know, if you're diagnosed? And I always tell people, do not give up hope. A statistic is a statistic. You know, there's one person who called me and said, well, you know, I know that X percentage people are not, you know, are only going to be alive after 5 years with this condition. That person is still alive now. You know, and again, we don't know. We're having breakthroughs every single day. So I just say always don't give up hope. And these are just something that, again, we can put on the website of tips that I think are helpful. Again, creating a folder, becoming organized, researching, meeting with your family and friends. Bring someone with you. I emphasize that. And again, always make sure you get a timeline. Thank you for your patience and attention. And I'm going to have the panel come up with me and have a seat so we can open up for discussion.
Yeah, at
They
this
will give
time-
their testimonial.
Okay, at this time, we'll have Annie, Jean, Valerie, and Douglas come up to the stage, and then Dr. Morita is going to join them on the table.
Yeah. So again, I just emphasize that they will give their own sort of perspective on it, and some of them, we might have someone coming in a little bit later on, I know coming from the Windward side, but they're going to give the reasons of why they chose therapy. Some actually even chose to refuse some types of therapy, and they all have unique situations. So I'm going to have them introduce themselves, and I'm going to have them, again, share their story, and then we're going to have time at the end for discussion.
Hi, my name is Annie, and if I can just give you a little bit of background for me, 18 years ago, I came to Queens to work for a surgical oncologist who is one of Dr. Morita's colleagues now at the Cancer Center. And so for me, cancer, I'm not a stranger to cancer. I was there helping treat patients with cancer. After a few years with working with that surgeon, I came to work for Queens. And I work for the imaging department where I schedule a lot of patients for imaging studies because of cancer. And so it was a little different for me when I went from being someone who helped coordinate things for patients and then becoming a patient myself. And so last December, I went to see Dr. Morita. Actually, it started in October. I went in for an MRI because I was having some symptoms. And through my MRI of my neck, I found out that I had a thyroid nodule. And after having a biopsy, I found out that it was cancer. And the first thought that came to my mind was that just a few years before that, my father passed away from lung cancer. But I never thought that I would ever get cancer because he was a smoker since he was 13. And there was no one else in my family who's ever had cancer. So I never thought, as I was helping patients, coordinate exams, coordinate biopsies, and surgeries, that I would be a patient myself. Well, I'm so thankful for the Queens Medical Center, and not just because I work here, but for the treatment that I got, when I became the patient. The first thing I had to do was actually open myself up to my peers. And the one thing is, you can't be ashamed of what you have. Whatever diagnosis you have, you can't be ashamed. It's cancer. And so I reached out to my friends who I work with on a daily basis, and I said, hey, look, I need a biopsy. I need this. And they were able to help me out, and as I went through the process from October, got my biopsies in November, and in late November, I met with Dr. Morita. And, I trust my doctors because for me, I've seen how they treated the patients. I've seen how they advocated for the patients. And so when he told me, hey, we need to take this out, I said, okay, let's do it. And within a couple of weeks, I was in the OR. And he went in, and for me, it was thyroid cancer that I had. And I didn't know when I went in whether they were just going to take one side out or it was going to take out the whole thing. And he said he was going to try to, salvage half of it so that I'd still have some function that the thyroid, gives the body. But when I came out of surgery, he told me, hey, the whole thing had to come out. I said, okay. And for me, the journey has been so fast from October to December when I had my surgery that, to me, that part of it was a blur. My family was there by my side the whole time, but it really was a blur until I got out of that OR, and then I was like, wow, now what? And, I've been so fortunate to have a great team of doctors that's been following up on me. And, you hear a lot that if you're going to have any kind of cancer, thyroid cancer is the one to have, because to survive thyroid cancer is probably the best. But there's still challenges. There's daily challenges. And through my endocrinologist's suggestion, I did not have radioactive iodine treatment. They felt like that they were able to remove all of the cancer. And so I never had that. I've had 2 tests since then, 2 tests to see if there was any cancer left. And both tests has come out clear, as if I've never had thyroid cancer. But today I'm still living through the effects of not having a thyroid. Because little did I know that thyroid affects your metabolism, your blood sugar. It affects a lot of different things, that little thing that goes right here. But like I tell my kids, I'm here to complain about it. And that's all I'm thankful for.
Just wanted to comment that you had a discussion with the other physicians and you chose not to get radioactive iodine, which is sometimes helpful in treating thyroid cancer. So it's important to have a discussion. That's why not everybody here has had all, everybody has a different background and different experience and what they went through. So that's why we wanted to give someone who said, you know what, I'm not going to get any more therapy besides surgery. So it's a choice, but it's a choice that has to be informed, and you have to know what the risks and benefits are. So thank you for sharing your story.
Good evening, and thank you for this opportunity to talk to you about my experience with cancer. My name is Dean Kawakami. I am 66 years old, and I was diagnosed with pancreatic cancer when I was 61. Pancreatic cancer is not something new to me. My wife's cousin had it, and on the mainland, and then we would go up to see him. And that's the first time I saw anybody that had gone through chemo and the side effects that he had. And unfortunately, he passed away, but he lived longer than what the doctors told him. And one of my coworkers was diagnosed with pancreatic cancer. He had all the symptoms prior to the cancer, but either he ignored it or the doctor misdiagnosed his conditions. And by the time that he really went to see the doctor, he only lived about 4 or 5 months and then passed away. So my journey with cancer began on the morning of December 21st, 2011. I was home on vacation and with my son. We had just finished eating McDonald's breakfast. And about half an hour or so after eating, I had this very excruciating abdominal pain. It was so strong that 1 second I was standing up, and the next second I was on the floor. I was on my hands and knees, and the pain was so intense. And the next thing I knew, all this water was falling on the floor. I was thinking where it was coming from. And then I found out it was coming from me. I was just sweating. I was just soaking wet. So after about a couple minutes or half an hour, I'd have my son drive me to the Queens Emergency Hospital. And then it was there that they did a lot of tests, the CT scan, blood tests, MRI, and so forth. And I was put into the hospital, and then the ER doctors finally told me that the prognosis was I had acute pancreatitis, inflammation of the pancreas. And it wasn't like food poisoning, so if you're supposed to eat at McDonald's, it's still good to eat there. But anyway, before my pancreatitis, I didn't have any of the symptoms that my fellow workers had, the backaches, the stomach aches, the nausea, feverish feeling, chills, rapid heart rate, swollen stomach. I had none of that. So it was a surprise to me that I did have this thing that came on real suddenly. So after about 11 days, I was dismissed from the ER hospital, and I fortunately missed Christmas. But the following month, during my follow-ups at Queens, I was told that I had white spots, which was diagnosed as cystic neoplasm, and they were, I guess, diagnosed to be a suspect for cancer. The word cancer is not something that you want to hear, especially for pancreatic cancer, because by the time most people find out, it's like terminal. So I was very afraid at that point. But because I had the pancreatitis, the doctors were able to discover the pancreas cancer and diagnose it as stage 2B. The white spots were in the tail portion of the pancreas, which is, I guess, the better portion than being in the head portion, because I understand that if you have it in the head, it's a little bit more difficult and complex for surgery as well as treatment. So I had it in the tail, so that was very fortunate. I had surgery in March of 2012. So after the surgery, I was told that 70% of my pancreas was removed, as well as 100% of my spleen. And I was kind of surprised at the spleen part, but they told me that somebody my age didn't need it anyway, so they took it out. Of the 43 nodes, lymph nodes that was, I guess, tested for cancer, none of the 43 showed any signs of cancer, so the cancer didn't spread, so I was very fortunate. After the following months, I was told that I would be doing some treatment, mainly chemo and radiation. Chemo was, for me, was 6 months long. It would be 1 day a week for 3 weeks, and then you get a 1 week off. The 1 week off was to see if your cells and everything reproduced and was enough so that you could go do another session. So I had 6 of these sessions, and what it meant for me was sitting in a chair for 1.5 to 2 hours with the IV. You can't move, you're sitting there. And it's something that you think about cancer while you're sitting there. And you can talk to the nurses, and they'll talk to you tell you about certain things, what kind of medications they're using and so forth. And it's kind of interesting. So if you have to go through it, just ask them, and they'll tell you, because, it's part of it is, if you're afraid of what they're doing, then just ask them, and they'll relieve you of your anxieties. At least it did for me anyway. So I went through the 6 months of chemo. I didn't have the symptoms of nausea, vomiting, loss of appetite, fever, or even loss of hair. At Queens, they have in the treatment center, they have these mannequin heads, and they have all these caps that people wear. And I had my eye on one of them, and after about 6 months, it was still there. So I asked the nurse, by the time I was finished, if I could have that one. And she told me no, because I didn't lose my hair. So after the chemo, I went on to radiation. And radiation is every day, except Saturday, Sunday. But you have to go every day. And this was for 6 weeks straight. So it was about 15 minutes long. But again, it's every day for 6 weeks. So that was more of a chore than coming once a week here for treatment of chemo. But again, I didn't have any side effects as in chemo. So I don't know all the side effects that people talk about. I guess I was lucky, or I don't know, maybe my immune systems or whatever was much better than other people. But I didn't get all the symptoms that associated with these two treatments. So I survived the surgery, I survived the chemo treatment, and I survived the radiation treatment. So I am a survivor. It's been 4 years and 4 months since the surgery, and I would be one of the 5% who live past the 5-year survival rate. Thank you.
No, just to give a little bit more detail, I did tell you that I was going to take your spleen, so sorry if you forgot. But, Mr. Kawakami had, actually left-sided pancreatitis. A lot of times the symptoms are a little bit more vague. Patients get weight loss, they will have some back pain, but what really saved him was getting pancreatitis, and that's what prompted the imaging and finding a tumor there. So he's glad he's extremely fortunate. So, but a right-sided pancreatic cancer, oftentimes patients will come in, they'll be jaundiced, they'll be yellow. But a left-sided pancreatitis, pancreas cancer, a lot of times it's actually too late because the symptoms, like I said, are very vague. Weight loss, kind of some back pain. So, but fortunately, you did get that episode of pancreatitis, and that started the whole workup. I'm going to have Ms. Campagnano introduce herself, and we already had someone here had mentioned about thyroid cancer, but she's going to provide you her experience. Again, all of these folks here, they're all survivors, but I didn't want to just have only patients that didn't have they don't have any active disease. She'll tell you about some challenges. So these are real life stories. This is not something that, everybody has some challenges. So I appreciate her bravery.
In 2014, I was looking forward to retirement. I'm a kindergarten teacher, and I thought, okay, I've had enough. I'm going to retire. But about the same time, I had like an ache on my neck and shoulders. So I thought, wow, it feels like I slept the wrong way. I went to see my doctor, several tests. I was told, oh, but you look too healthy. You're probably fine and everything. I did more tests, and there was a tumor at my back here. And so I had that removed, and after that, we went to see Dr. Morita. Dr. Morita actually early on had said that, oh, there's a drug that was newly okayed by the FDA. And is that the one that I'm now taking? So I thought, okay, why do I deserve this? And I think everybody thinks that when my husband hates when I say that, but, you know, you think, what did I do to deserve this, you know? And it took a while to actually say the C word. It's like, oh, you don't want to say it. And some people don't want to talk about it. I really don't want to talk about it to anyone in the beginning. And then you realize, no, it feels good to talk about it. I also asked Dr. Morita's office for a suggestion as to who I could talk to, because I felt like I needed therapy to talk to someone. And it was suggested I go to this group, sponsored by Queens, and it was wonderful. It was 10 sessions, and several of us still get together. We go to lunch once a week, and we talk about what we've been through, and it certainly helps. What Dr. Morita said about don't give up hope, that is so important, and your outlook is so important. I started taking this chemotherapy pill, Imatinib or Lenvima, and my numbers, my thyroid globulin levels is what my doctor keeps track of, and it went as high at one point to the 500s, but since taking this Lenvima, it's down to 9.
9.7, right?
9.7. So that's great. It's kind of under control. I go to check regularly, but there are side effects. My hands and my feet are very sensitive. I'm tired often. Sometimes I feel a little loopy, but I don't know if that's old age or the drug. Sometimes I feel nauseous, but like Annie said, you know, at least I'm around to complain. And it's great because I get up in the morning, and sometimes I feel better than other days, but, you know, I get up and I get to spend time with my husband, or I get to work out in the yard or do my little sewing, and especially now I spend time with my new 3-month-old grandson, which is, I would suggest that as therapy for anybody. If you could get a grandchild, that definitely helps. But, you know, I deal with it, but it really is don't give up hope. And really, a positive attitude really helps. And I'm not saying that I'm that way every day, but it definitely helps. And another suggestion, like Dr. Morita said, is when you do go to all your doctor visits, take someone along. My husband comes with me all the time with his little black notepad, and he takes down notes, and we think about, oh, we should have asked, so the next time we go and ask, but it really helps. Another thing is to be your own advocate, because yes, sometimes you feel like you're the only patient and you're the one that's supposed to be up there at front, but you know, there are many like us. And sometimes like something wasn't scheduled for you, well, you have to call and tell them, oh, you know, could you please schedule this for me and call it in for me? That's just something you need to do for yourself. I think that's it.
Is it okay if I give some details about how you presented?
Sure.
Because, you know, your thyroid cancer was discovered in your bone, in your spine. You've already heard someone who will say, you hear this, oh, thyroid cancer is a good cancer. I don't know of any cancer that's good. I mean, it was in her spine. And so the medication that she's taking now is a form of targeted therapy that I had mentioned earlier. Remember, I talked, there's different advances. So this is a fairly new drug, but it's called Lenvatinib, and that's looking to hit on different parts of the tumor itself. But again, there are side effects, but what she's technically not undergoing is traditional chemotherapy. So she goes home every day and she basically takes a pill. And so her thyroid globulin level is what we follow, because without a thyroid, you shouldn't have much thyroid globulin. It's kind of like prostate cancer. You shouldn't have a PSA that's elevated. So her thyroid globulin, as she mentioned, was in the 500s. Now it's under 10. It's 9.7. I mean, that's phenomenal. But she still has some, you know, residual, some disease. So she's still undergoing treatment. But she is, again, I still look at her as a survivor. And I don't care about statistics. I tell you, everybody's an individual, right? Mr. Kawakami, if you look at all pancreatic cancer statistics, shouldn't be here. In fact, I think his wife told me, and I don't want to give the wrong information, but one of her friends had the gall to say, did he actually have pancreatic cancer? Because they couldn't believe it. He had the real deal. He had pancreatic adenocarcinoma. So he didn't, so a statistic is a statistic, is what I tell people. You make it of it what you want, but you positive attitude and your will, and these folks are progressing and doing well. I want to also bring up here Mr. Stewart. He'll introduce himself, but he's undergoing a form of neurotreatment that I mentioned as a promise would have is immunotherapy. So he's been through different types of immunotherapy, and I'll let him talk about his own experience and share his testimony. So I appreciate him coming in, and I know his wife brought him here too. Thank you.
Yeah, growing up in Hawaii for the past 66 years, sorry. Okay, here we go. Growing up in Hawaii for the past 66 years, everybody's got their share of the sun, huh? And I figured, started going to the skin doctor for the longest of the time religiously, and one day I said, hey, doc, we need to take a look at this spot on my shoulder here. Well, it turned out to be a melanoma. So with a few tests and stuff done, we noted down in the spine there was an area, so Dr. Morita did a little surgery and at least took out the on my shoulder, and we had to go from there. So we decided on the IL-2 treatment, and that consisted of going to the hospital for a week on, taking I don't know exactly what you call it, an IL-2, getting a PIC tube installed, and getting every 8 hours infused with this IL-2, and it amounted to treatments as much as you could take. Taking hooked up your bodily functions. They monitor what's going on, and hopefully, I don't know exactly the count, but they would keep doing it as much as you could take, and you could feel it was getting to you after a while, and they would have to stop. So that went on for, you were in for about a week, and then there was off a week, and then one more week of that same treatment. And then after that, I was off, I think I was off a month, and then again, started the 1 week on, 1 week off, with the PIC tube and the whole thing. Of course, meanwhile, you get the PET scan and the various MRIs monitoring what's going on, and we I think it took care of the tumor in the spine there, the melanoma in the spine, but we noticed in the pelvis there was a spot there that showed up, and we decided on radiation to take care of that, which it did. There was a little pain there, and sure enough, it showed up as a melanoma there. But like I said, if I can, what kind of radiation we had here. Anyway, that took care of it. So the next step, again, PET scans, radiation showed still an indication of let's see. After that, we went into why. No, I try to forget what I want.
No, it's okay.
Through. But going back to the IL-2, that was a little bit traumatic. I think I got actually. I got actually a free skin peel. I mean, I looked a lot of years younger after that, but.
How many days were you in the ICU? Sorry to interject. You're in the intensive care unit, correct?
That's when I think we just first started, and they really didn't have rooms set up for that IL-2. And then, it was not good watching people getting carried out around you, but I was determined I wasn't going to be one of them. So the question for that was?
No, I just wanted to mention, to all the folks here that you were in the intensive care unit getting treatment.
Yeah, that was...
There's a lot of side effects.
Yeah. So I went through all of that, and I said, oh boy, I hope it's going to be all worth it. Well, I'm up here talking. So anyway, the next treatment was a Yervoy. It was an IV down here at, in the office. That was the next treatment there, and it didn't. It gave me side effects to a point where the hormone was affecting my hormones, and it wasn't really helping out that much. So we. Boy.
It's okay. So you did ipilimumab, which was FDA approved, also known as Yervoy, which was approved in 2011. Now you're on an anti-PD-1 inhibitor. Okay. Right. Nivolumab, I believe. Opdivo.
So yeah, then we decided to go to the Opdivo, and which I am on now. Up to that treatment involves IV every 2 weeks, and so far so good with PET scans and stuff. It's the cancer is really not progressing at all. In fact, it's actually shrunk. So let's hope it stays that way. Like I said, every 2 weeks I'm still doing that up until, I don't know, Doc, whenever.
Timeline is to be known.
Time will tell.
And that commercial that I played for some of you, most of you that are here, I mean, that's being, marketed for lung cancer, but it's really first approved for melanoma, and that's what you're undergoing. And maybe talk about what you do as far as your work and how has that impaired your function now that you're on this therapy. If you don't have to give your company name, but I mean, what you do. That
yeah,
you still
I was hoping to retire, and I still may, but it hasn't affected my function at all. Actually, I feel great. The Opdivo, you just go in, it takes about an hour IV, hour, 2 hours, and you're out of there, and you wouldn't, no worse for wear. So it's all good, yeah.
Again, so that's the form of therapy called immunotherapy, and you've had really the whole panel, and this is one that we're hoping will control your cancer. And again, there's been a lot of news and data about its efficacy for not only for melanoma, but now for lung cancer and other types of cancer. So there's a lot of clinical trials that are looking to see if it's going to be helpful in other patients who have different types of cancer. So I appreciate all of you sharing your story. All of you are very, as far as I'm concerned, you're all my heroes, because it must be very difficult to come up here and really show your vulnerability. And some of you who are actually undergoing active treatment too, I really commend you. I think the part that I always get from my patients is that they may be done with the physical side effects, if you will, but there's still an emotional toll. And whether you're stage 1 or stage 4, I think it still always is with you. So again, I appreciate your bravery and loyalty. Maybe, Lisa, I want to make sure we had some time for questions.
Yeah, this time, if you have any questions for Dr. Morita or our guests, please raise your hand.
Are immunotherapy side effects always intense and severe?
Well, you can say Mr. Stewart. I mean, I don't want to speak for him, but what are your side effects right now? I can mention, he had the ipilimumab, which was approved in 2011 for melanoma, and he talked about some hormone dysfunction. It can destroy your pituitary gland. Your pituitary gland makes hormones that your body needs. And I have patients that are actually taking supplementations because it destroyed the pituitary gland. And so some of them have problems where they need steroids and just other supplementations, so it does affect them. And then some patients who are on these newer anti-PD-1 agents that we mentioned, Opdivo and Keytruda for treating for melanoma and lung cancer, the side effect profile seems to be a little bit better, but I don't want to speak for you. What are your thoughts on the side effects that you have right now?
Right now in Opdivo, they're not much compared to the ones in the past.
Yeah.
Actually, you like I said, you're no worse for wear. If it stays that way, it's all good. Yeah.
So some of the side effects for the ipilimumab, for example, it can actually attack your colon, and people can get colitis. There's been reports of ruptured colons, people needing emergency surgery. So no therapy, just like surgery, there's nothing that's without risk, and there's always side effects. So that's why I always tell individuals, make sure you made an informed decision, not just a decision that's quick and say, okay, but you've really had time to think it out and discuss. And you know what? It's not a crime to go and get another opinion too. You have to have trust with your physician, whether it's a surgeon. I mean, I think I probably talked to her once before surgery, before she said, okay, we're going to do it. But, it's okay if you want to go seek another opinion because you're not comfortable, because no matter what, whoever's going to be taking care of you, you have to have that trust. Truth, and it is, you only get one life. So don't feel bad if you want to get a second opinion. But I think the side effects can be variable as you discussed. So some of them can be severe, diarrhea, skin conditions. What Ms. Campagnano undergoes right now with the lenvatinib, which is a form of targeted therapy. You may think, well, it's a pill, it can't be that, but you can still have side effects. It can involve the skin and be very painful. So just because it's a pill, that doesn't mean it doesn't have side effects. But great question.
Any other questions?
I was wondering if you have a cyst in your pancreas, what is the chances of getting cancer?
Good question. So it depends on how much fluid. Is it a complex cyst, meaning is there some solid components? If it's a pure simple cyst, really the chance of cancer is essentially nothing. But if there's a solid component that it needs to be at least followed, if there's suspicious characteristics that your doctor can talk to you about, such as what's called a mural nodule, that would make me worry that you might have pancreatic cancer harboring, and that's what happened with Mr. Kawakami. So he had kind of this cystic neoplasm where some of it was kind of water, because a cyst is basically a fluid-filled entity, but he had some areas that were solid, and he ended up having pancreatic cancer, the real pancreatic adenocarcinoma. So it really depends on the characteristics of it on MRI.
I also ask, when they say that they don't do anything, they just say to wait because they say it's precancerous. So for myself, they didn't recommend anything. They said they could go in and see if it's cancer, but they didn't feel it was cancer. So they told me to wait. So by just waiting, I took on myself to treat myself. So I went on a macrobiotic diet to prevent cancer. And I don't know if it's helping, but it's been almost two and a half years since my MRI has been not negative, but it hasn't increased in size. So, but they told me I'm too old to be having too much treatment because, whatever surgery, they won't do it. I'm a little medically trained, but they won't do Whipple and stuff like that. So I said, I know everybody has to die sometime, but I told my doctor I didn't want to die yet. So that's why I treated myself.
Yeah, I'm not sure if that diet is impacting the growth, but sometimes as long as it's being monitored and it's not growing, it's not changing, I think you're pretty safe. Another way of getting the information, if it's in the pancreas, is you can just biopsy it. So not knowing all the details, but in general, not just because you have a cyst, that doesn't mean you have cancer in there.
I think we have a question on that side.
Hello. Okay. Yeah, Doc, I appreciate the information and the new treatments that are going out and looking at the patients up there. My question is, because early on you mentioned don't give up hope, and you need to have a will to survive the treatment that's going on. I guess the question really gets back, is there a percentage when you find patients that really have a lot of hope, a lot of support, and a lot of will to live, the percentage of effect that has on survival of the cancer in there? Can a number be put on that at this time?
You know, I don't know. It's just my anecdotal experience. I think it really is dependent on a few things. One is I always talk about the stage, the type of cancer, but I just see that patients seem to do better. I mean, the vast majority do much better when they have a good attitude and a good support system. I really think. I mean, think about it. Just like melanoma, right? What are we using to treat melanoma now in the year 2016? We're using the immune system, right? So I think it somehow plays a role. I can't give you hard data for my patients as far as percentage, but I know that the vast majority seem to do much better when they have, just a more positive and optimistic attitude. And that's why no matter what the situation is, I mean, we try to be realistic with our patients, especially if they have late stage disease. But I tell you, there's some people that you swear are going to die and they don't, or a new therapy comes along. I mean, all these drugs, like what Mr. Stewart is on, this drug just came out recently. Now they got commercials for it. And so the longer you're on, the more chance that you have that maybe there'll be another breakthrough. Because look at all the FDA approvals that it's just coming just one after another. Cancer care has changed from 10 years ago even. A lot of people who trained 10 years ago, this is all new to them. When I was using some of these drugs in my experiments, I never thought that they would be actually used in humans. And some of the drugs that we gave when I was at the NCI and people got sick because we're trying to figure out what the best dose is, and now they're approved by the FDA to be given. So when I say hope, it's not only for, what's my attitude? I'm talking about there may be breakthroughs that come along. You just never know. Cancer care has changed the last 10 years. It's a major revolution.
Thank you.
I just wanted to say thank you all for sharing your stories. I just wanted to know, you had mentioned that challenges that you face with no thyroid, and I was wondering if you'd be able to share what kind of challenges there were, or there are.
Almost immediately, I did get much more tired right after surgery. And then I finally got on levothyroxine, which replaces the thyroid hormone that I lost when I had my thyroid removed. The other thing was with surgery, my parathyroid was shocked, so my body was not producing any calcium. And so I had to go on calcitriol, which is it's like vitamin D, which helps me absorb calcium from the foods I eat. But also I was on calcium carbonate, which I was taking so much, like 4 to 6 times a day. I eventually got off of it a couple of months ago. But for some people, it's easier to get off of the calcium. For me, it took a little bit longer. So I had muscle cramps, and it wasn't just like sometimes you don't drink enough water, so you get muscle cramps at night or something. It was constant. I had aches, body aches. Some of the other things that I am going through is I've just recently discovered an irregular heartbeat because of the thyroid hormones that I'm on. So it's just like things that develop along the way. And although my thyroid cancer is different from having to go through chemo or radiation like other cancers, there are different challenges. It's something that you can, you can work through though.
And that's a good point. Your body needs some time to adjust to what's going to be your optimal dose. So there is the time that you work with your endocrinologist. And sometimes patients do develop a low calcium because sometimes the tumor is involving the areas near the parathyroid glands, and the blood supply can suffer. So there are, in surgery, there's side effects just like there is with targeted therapy and immunotherapy. But the key is to get over the physical ailments and, again, try to, be emotionally prepared to fight, to continue to fight, whether you have existing disease or you're worried that you're going to get recurrent disease. So it's really a lifelong battle, I think.
Okay, other questions?
Hi, thank you so much for your stories. I have a question for Dr. Morita. You mentioned second opinions, and recently I was diagnosed with cancer, and the oncologist said we need to move right away, and I called 2 different oncologists for second opinions, and they just said flat out, their offices said they don't give second opinions. So I wondered what kind of strategies you might suggest for second opinions in that case.
I don't know what the policies are, but I think, I would basically ask that question at the time of that appointment, and that's why it's at the initial appointment, and that's why it's really important to have a huddle before, once you get diagnosed, have a plan of what are you going to do. Are you going to ask that about a second opinion? And you have to demand a reason. If not, there's other facilities too. We have a relationship with MD Anderson, as you're well aware, where we can also reach out to them and they can provide some collaboration as well. So, there should be no reason that you can't get a second opinion. I think sometimes certain cancers are they're a little bit more regimented, where the standard of care is pretty obvious. So I think sometimes getting a second opinion may delay your treatment, but it really depends on the amount of trust that you have with that physician. Like I said, many times, and I'm being very, very open, I meet the patient once, and then we're signing up for surgery. It just depends on what kind of connection you have, So it's hard to describe. And I'm a little biased, but I think in surgery, it's the most intimate form of medicine. You're touching the patient. You're there at the time of therapy, and so I just really try to, try to develop as much rapport. So it really depends on the connection that you have with that physician. So don't feel bad about it, but again, sometimes it may be your doctor saying there may not be different options per se, and it's pretty standard. So you'd hate to delay therapy too. So, but great question.
You have one back here?
Earlier, you were talking about some statistics that were Hawaii specific. Is there a good website that you can go and read about Hawaii specific?
Yeah. So I can actually. If you just search for American Cancer Society 2016 statistics, there's actually a handbook that they come out with, and they'll give you some figures for the state of Hawaii. And I know Queens, we have a website, but also University of Hawaii Cancer Center, you might be able to get some statistics there locally. But I know I'm part of the Comprehensive Cancer Coalition for the state of Hawaii, so we're going to be updating the website soon with new data, hopefully within the next 6 months or so.
Okay, one last question. Please raise your hand.
It's a comment and a thank you. So Dr. Morita, thank you so much for being so open. Unfortunately, not every physician that maybe some of the people here have had that openness, and that woman in the front who said, I'm of a certain age. sometimes I hear that. I'm the AD over at Susan G. Komen, and we get calls from people saying I'm a certain age and they won't give me a mammogram anymore, or I'm a certain age. But I really feel like people need to, as you were saying, advocate for themselves, have a team of people who is going to back you up. And, you know, who's to say what age is what? We all are at different places, and with precision medicine and looking at who we are and what kind of lifestyle we have, I mean, sometimes we're living longer, so why not cure the patient and forget about the age of the patient? And I commend you for the work that you're doing. And I also want to let you know that we have some resources back there. So if you're newly diagnosed and if you need some questions to ask, we have some available. But thank you so much.
Thank you.